morning, everyone. Thank you so much. Thank you so much for your patience as we get started here. My name is Jaafer Golzar. I'm going to cut this pretty short because we have some live cases coming up and we have some great speakers for you. So I'm just going to cut this short and go through this as soon as possible. As I mentioned, my name is Jaafer Golzar. I'm a cardiologist in Chicago and the course director for the Chicago Endovascular Conference. About 5 years ago, myself, Dr. Amir Matarjameh, Jack Chamberlain, and Paul Jones came together and put this meeting together with the mission of delivering comprehensive, practical, and progressive education, highlighting a multidisciplinary approach to treating patients with peripheral arterial disease. Because I don't care if you're a vascular surgeon, an interventional cardiologist, an interventional radiologist, a podiatrist, a nurse, you can't do this by yourself. You need the team. You need the entire team if you're going to save limbs. Patricia Thorpe is our Venous Program Director, John Dale Jenkins, Podiatry Chair, Wendy Ambrose Gavin, the Nursing Program Chair, and Walter Murphy is our Radiology Tech Program Chair. I will say, as I put the slide together, I asked everybody to give me a picture of themselves, and Walter gave me a picture from about 30 years ago. So that's why it's in black and white. But he looks good. He still looks good. So CVC is a simultaneous arterial and venous meeting. So you can stay here a little bit, you can go next door, learn some venous content. We start off today with critical limb ischemia, limb salvage stomach, and that's going to go on all day today. Tomorrow we're going to get into atherectomy, complex arterial revascularization, renal denervation, the business of vet medicine, which is always a highlight of the meeting. And then into Friday, the aortic aneurysm summit and carotid disease. In the venous side, we're starting off today with venous compression syndrome, venous stenting, going into venous thrombosis, superficial and deep venous disease, phlebectomy, sclerotherapy, and then again, business of veins. Saturday, IVC filters, pulmonary embolism, and something really interesting we're going to do, we're going to have live patients on Friday afternoon that we're going to be scanning with ultrasound with our ultrasound techs and really being able to teach you guys what is normal and abnormal venous anatomy. How do you do elicit reflux? Live case sites this year, Tom Davis from Detroit, Michigan, Jack Chamberlain from Elk Grove Village, Illinois, Mark Woolley from Pittsburgh, Ross Milner from Chicago. Patricia Thorpe is going to be doing some pre-recorded live cases, as well as Jorge Trabal, Romy Chopra, and Paul Jones. I want to thank you guys for being here. Our sincere thanks to all of you that have taken time away from your practice to come here and learn how to treat your patients better. Our scientific committee, which has helped develop this content, obviously our faculty. We couldn't do this without our faculty that have taken time away from their practice, from their families to join us. We don't have any honorariums. All we do, they're here because they want to teach you. They want to interact with our attendings and each other. And more importantly, our commercial and grant supporters, because without them, we could not put this meeting on. It's very, very expensive to put on a meeting such as this, and we strive to keep our costs down as low as possible, and without our supporters, we couldn't do it. This is a CME meeting, so the content is not influenced by the companies. All they ask for in return is 5 minutes of your time to stop in the exhibit booth, to talk to them, so they explain to you what their products are, what they have to offer. And I humbly ask you and request that you do that, not only because they bring you the new technologies that help improve patient care, but also to thank them for helping us and so that we can continue to do this. This is our CVC team. Renee is our executive director, has been working tirelessly over the past year putting this meeting together. Gwen and Joanne with Lux Travel, you probably have interacted with them if you're doing any travel, and they're also here for on-site registration, and Max is there for the speaker ready room. If you don't have very good internet access, which you really won't have down here, you can log into the Wi-Fi access using PSA fee, and password is Endologics, and we thank Endologics for sponsoring that, as well as we have an app that will bring you up-to-date agenda, faculty information, and exhibitor information. We're really, really excited about this, and I'm going to end with this, is our ultrasound-guided pedal artery access cadaver course on Saturday. So we're flying in 24 cadaver legs, which will be fluid injected. We're going to have ultrasound machines and the faculty that you see here that will be there and available to teach you guys how to get pedal access. So it's fluid injected, so it simulates real-life pedal arteries, so you can actually practice how to obtain pedal artery access in cadaver legs. And this brings us into amputation prevention, and that's what today is all about, is preventing amputation. And I'm just going to go over a couple of these statistics. You know, BKA has about a 5 to 8% perioperative mortality, and only about half of these people actually gain mobility after a below-the-knee amputation. An above-the-knee amputation has an 8 to 12% mortality, and only 25% of these patients develop mobility after an above-the-knee amputation. And we know that most of these patients are dead in 2 years. Our scientific age demands that we provide definitions, measurements, and statistics in order to be taken seriously. Yet the most important things in life cannot be precisely defined or measured. How do you explain statistics to a patient that says, I wish I could finish a marathon or do a walk with my family? This was a patient that could not do that last year. She called me a couple of months ago, excited that she was able to finish a 5K run with her family. How do you measure a patient like this has had 6 bypass surgeries since he was 40 years old. He's currently 52. With his after his last bypass failed, they told him that he needed a left lower extremity amputation. We saved his limb. He gets restenosis. He absolutely gets restenosis. Every 6 to 9 months, he needs a little touch-up work, but it's much better than losing a leg. This is one of my favorite patients, 92 years old. He lost his right leg in the war. He's had a prosthesis since then, and he hobbles around with his prosthesis and sometimes on one leg, and he takes care of his wife who has severe dementia. And he had severe peripheral arterial disease, had an ulcer on his left leg, and they were going to do an above-the-knee amputation on the left leg. And he came to me and he said, "Doctor, if I lose my left leg, I won't be able to take care of my wife and she will die." We saved his leg, and he's continuing to take care of his wife. These are the things that you cannot measure. These are the things that are not reflected in statistics. Limb salvage is what we should strive for, and the paradigm is shifting. In 1517, Gersdorff described amputation as the primary mode of therapy for patients with disease of the limb. In 2014, it is still the primary mode of therapy for patients that have peripheral or patients that have gangrene and critical limb ischemia. So I went back and I said, you know what? We have so much technology now. We're doing so much in the field of science. What else are we doing? We're almost at the brink of curing HIV. This year, a bionic eye was used to restore sight to a blind man, was implanted into his eye, and a camera in the glass to allow a man to be able to see again. Better yet, scientists create robotic sperm that have a magnetic tail and attached to a spermatozoa, and they use magnets to actually take this towards the egg and fertilize the egg. So we've advanced our technology in medicine so much. Is this the best that we can do for patients with gangrene and peripheral arterial disease? I don't think so. We do it through patient education, through healthcare provider education, because if your primary care doctors, if your podiatrists don't know that we can save these limbs, they're not going to send you patients. Through educational meetings such as this, through like NCVH, like CVC, supporting industry, because without industry, without their advancements in technologies, we couldn't do what we're doing. Welcome to CVC, and let's make a difference.
Can we do that?